안녕하십니까. 발질환 무엇이든 물어보세요. 이우천입니다. 오늘은 제가 여기저기서 여러 나라에서 여러 학회에서 발목관절염의 교정수술, 어떻게 하면 발목을 관절염이 일부 침범된 관절을 자기 관절을 그거를 쓸 수 있을 것이냐, 관절염이 악화되지 않도록 하고 호전시켜서 관절을 쓸 수 있을 것이냐, 거기에 대해서 여러 군데서 강의를 한 게 있는데, 제 강의를 그걸 의사들 대상으로 한 것과 이제 그리고 일반인을 위해서 제가 이렇게 유튜브 동영상을 만들어서 보여드리고 했는데, 오늘은 그 강의한 것 중에 한 개가 제가 미리 동영상을 만들어 가지고 보낸 그런 학회가 있었습니다. 그래서 제가 그것이 인도 학회 2020년도 8월 달에 이제 코로나가 퍼지면서 자연히 이렇게 방문해서 강의를 잘 못하게 돼서 이렇게 온라인으로 강의하고 이런 각 학회를 자꾸 하게 되고, 그래서 그 중에서 이제 하나가 인도 학회에서 하게 되고, 여기서 미리 강의한 내용이 있어서 제 이런 내용에 대해서 한국어를 잘 이해하지 못했든지 이런 분들이 있을 수 있을 것 같아서 영어로 된 강의 내용을 뒤에 이 소개 뒤에 덧붙여서 보여드리는 동영상을 하나 만들었습니다. 그래서 이거는 2020년도 인도의 학회에서 한 건데, 어드밴스드, 그러니까 이렇게 좀 의사들 중에서 좀 이렇게 전문적으로 더 하는 사람, 경험 있는 사람들을 위해서 한 강의입니다. 그래서 풋앵클 족부 족관절 미팅이고, 이거는 이제 이 사람들의 이제 좌장, 이 학회를 주관한 인도의 대표적인 족부 전문 의사들입니다. 거기에서 보면은 제가 요 세션에 그 관절을 좀 더 좋게 하는 그런 거에 대해서 강의를 해서 그거를 보여드리려고 하는 거고, 제 이 인사 말씀 뒤에 바로 덧붙여서 그 동영상을 보여드리도록 하겠습니다. 대단히 감사합니다. Hello everybody. I'll talk about the supramalleolar osteotomy for ankle arthritis, and thank you for your invitation for this meeting. The supramalleolar osteotomy is an osteotomy at the supramalleolar level, and usually medial opening wedge osteotomy is performed, and less often medial closing or dome osteotomy is performed. Then rarely I use lateral closing osteotomy to correct the deformity. Why medial opening wedge osteotomy is more commonly used? Because it causes less surgical trauma. It is very easy to adjust in the amount of correction, and you don't need to bone graft in most cases. And also initial stability is very good, and healing occurs in a very predictable manner, and almost no delayed or non-union occurs in my practice, and no shortening occurs. And there are discussion points about regarding the medial opening wedge osteotomy, regarding the fibrillar osteotomy, and the location of osteotomy, and how to open the osteotomy, and how much correction is desirable. Regarding the fibrillar osteotomy, I do fibrillar osteotomy to translate the ankle laterally and also to prevent narrowing of the ankle mortise. Tibia-only osteotomy, which is shown on this radiograph, the tibia-only osteotomy often results in medial translation of the ankle and fails to correct the translation of the talus, which means on this radiograph, the talus is medially located relative to the tibial axis. And this is the intraoperative for the radiograph of the medial tibia-only osteotomy. As you do this osteotomy, the tibial plafond is corrected into valgus angulation, but the talus is still located, most of the talus is located medial to the tibial axis. So I do fibrillar osteotomy in most cases, and I make the osteotomy at the proximal border of the syndesmosis. This is intraoperative radiograph that I use I insert two K-wires in the tibia and fibula to determine the level of osteotomy, and I choose usually the proximal K-wires on this radiograph, and this is the post-operative radiograph. How can I open the osteotomy? I use the pre-bent tibial plate, which is less curved, less bent than the curvature of the medial surface of the distal tibia. And here, the red line is the line of osteotomy, and I apply the tibial plate on the medial surface of the tibia, and there is a gap, little gap between the tibial surface and the tibial plate. As you tighten the screws in, the distal part of the plate pushes the tibia laterally. And I also use thin osteotomes in osteotomy site to assist in the opening of the osteotomy. And as I make the osteotomy incompletely, not through the lateral cortex, the lateral cortex is preserved, and I usually don't need a bone graft in the gap. But if you make a tibial only osteotomy, you have to make all the way through the osteotomy all the way through the lateral cortex, and you need some type of bone graft in the gap. And how much should be corrected? I usually aim to correct the tibial plafond to neutral or slight valgus. This angle, usually 92, 93 degrees, is my purpose of the correction. And I usually would like to translate the talus slightly lateral to the tibial axis, as is shown on this radiograph. The larger portion of the talus locates lateral to the tibial axis after correction. And my opinions about the overcorrection into large valgus, I don't like to correct the tibial plafond into large valgus, because I found that large amount of valgus correction could not correct the talar tilt, and increased loading at the lateral aspect of the knee or ankle causes some problem in the long time, and lateral impingement occurs as synostasy, and large valgus may cause medial translation of the talus. This is one of my earlier cases, which I corrected the tibial supramalleolar osteotomy into large valgus, and the patient is, the symptom is much improved, but it's not, I don't think it's a physiologically good position. This is another patient with large amount of varus talar tilt, and I corrected the deformity like this, and the talus is laterally located to the tibial axis, but the osteoarthritis worsened within a year like this. So I don't think large amount of valgus correction is not desirable or better than the neutral or small amount of valgus correction. So I usually aim to correct the tibial plafond into neutral or slight valgus relative to the tibial axis. Another type of distal tibial osteotomy is distal tibial osteotomy without fibrillar osteotomy, which is shown on this radiograph, which intentionally narrows the width of the ankle mortise, which is indicated for ankle with wider mortise relative to the width of the talus, but it is rarely performed in my practice. This is intraoperative photograph, and there occurs a large gap, and it is a little unstable and more difficult than medial opening, which supramalleolar osteotomy. This is the immediate postoperative radiograph, and as you see, a large bone graft is filled in to fill the gap. After hardware removal, I found out that this X-ray is better than the initial one, but talar tilt is not corrected. So I don't think, I also found that this type of osteotomy could not correct the talar tilt. The other type of osteotomy is lateral closing osteotomy, which requires more soft tissue dissection, and it is difficult in fine-tuning of correction. A little amount of correct shortening may occur. It is only used when there is a large scar contracture on the medial side. In this post-traumatic case, there was a large scar on the medial side, so I could not open the medial side. In this case, I performed lateral closing major osteotomy. The result was good, but there is more soft tissue dissection than medial opening major osteotomy. The other type of osteotomy is dome osteotomy, which is second most commonly performed in my practice, second to the medial opening wedge osteotomy. It is a little more difficult, a little more soft tissue damage, but and also there is a possibility of delayed or non-union because you have to make the complete osteotomy from anterior to posterior. But it is useful when you need to correct large amount of angulation. As is shown on this slide, there is a large amount of varus, and you make an osteotomy like this, just above the syndesmosis. This is intraoperative photograph, and this is the post-operative radiograph. This is another case with a large amount of varus, and the proximal alignment is good. So, and the ankle is already lateral to the hip-knee axis. And if you make an open wedge osteotomy on the medial side, then the ankle will be far lateral to the hip-knee axis. In this case, I prefer to the dome osteotomy, and I correct the tibial plafond into varus, and I simultaneously translate the tibial distal fragment medially, so the ankle will be located in the hip-knee axis. This is another case with a severe varus deformity, a 50 years old lady. So I think it is too much advanced for joint preservation surgery. But in this case, the patient was young, and I tried to correct the deformity. So there's a hip, knee, and there is a proximal varus deformity, and the ankle heel is in varus deformity. So, and this is an preoperative weight-bearing CT. As you see, this is a too much advanced for joint preservation. In this case, I performed dome osteotomy to translate the this ankle into medial side and also correct the tibial plafond varus. And in this patient, tibialis posterior transfer was also simultaneously performed. So this is a postoperative X-ray shows which the beautiful alignment of the hip, knee, ankle, heel alignment. This is a postoperative weight-bearing CT. So in summary, I try to align hip, knee, ankle, heel alignment in every case. So I always take whole limb alignment, including heel. And when I make a medial opening wedge supramalleolar osteotomy, I do fibrillar osteotomy in most cases because I try to translate the talus lateral to the tibial axis. And I make the osteotomy at the proximal border of the syndesmosis. And I like the osteotomy like a green stick fracture, which means preservation of lateral cortex during the osteotomy. So there will be no problem with healing. And I try to make the osteotomy the tibial plafond into neutral or into minimal degree of valgus, not into a large degree of valgus. This is my presentation, and thank you very much again for your kind invitation to your society. Thank you very much.
Thank you very much, Professor, for accepting our invitation and making a very lucid presentation of a very, very difficult subject. Can we take up some questions?
Yes.
Sir, could you just elaborate onto your pre-operative planning and what kind of long leg X-rays you take?
What kind of long limb X-rays, which include which is shown in an article in JBJS, which include hip, knee, ankle, and hind foot, which is a whole limb radiograph including hind foot, which I take in weight-bearing state.
So it is from posterior to anterior. It is not like the routine radiographs which our radiologists take.
Yes, I think so. Yes. Yes.
So any other preoperative planning modality you use? You just take the X-rays, you take CT scan also?
Definitely I take weight-bearing CT in all cases at the time of diagnosis.
Okay.
And also for post-operative follow-up.
Sir, could you let us know about other adjuvant procedures together with the osteotomy? Do you do like ankle arthroscopy or ligament balancing?
At the time of supramalleolar osteotomy?
Yes, sir.
First 100 cases, I did a arthroscopic examination for every case. But after that, I don't need to, I do not do it any further because it is not great helpful, better in determination of the procedure for ankle arthritis. So I don't do it now. The ankle arthroscopy, in most cases, I don't do any more arthroscopic procedures. But I do lateral ligament reconstruction, repair, because I need to remove the lateral spurs. There is a, in most cases, there is a hypertrophic spurs and bones in the lateral gutter. If you don't remove the gutter, then there will be difficulty in relocation of the talus into the ankle mortise. So I remove the spur, then I need to repair the ligament.
Sir, what do you do for the valgus deformities of the ankle?
Valgus deformity is another very interesting subject, and I do the similar procedures for early and more intermediate stage valgus arthritis, but today I don't think it is appropriate to talk about it because it is too long subject.
Okay. Sir, what are your indications for total ankle replacement?
Total ankle replacement. Everybody agrees that it is a end stage ankle arthritis. I do total ankle, and I do in my practice total ankle and joint preservation surgery in a similar number in a year.
Okay. Sir, Dr. Nikesh Shah is one of our co-moderator. He wants to ask some questions. Dr. Nikesh, over to you.
Yes, thank you.
Hello, Professor Wu.
Yes, hello. Hello, Dr. Shah.
Hello.
Yes.
Yes. Can you throw some light on what is the conversion of from supramalleolar osteotomy to ankle arthrodesis or ankle replacement, or how many years this procedure works for pain relief? What should we tell to the patient that this procedure is effective for how many years, and what is the conversion rate from supramalleolar osteotomy to ankle arthrodesis or ankle replacement?
I think it depends on the degree of arthritis prior to the osteotomy. If you treat a patient with only minimal degree of talar tilt, I think talar tilt is very important for the prognosis. And my indication is, as is shown my GPJS article, usually less than 7.5 degrees. So in that case, in most cases, I think it lasts long time because I have no experience. I have done it only since about 20 years ago. So I don't have a longer time experience, but in my experience, if the patient has a small degree of talar tilt and it is a medial translation type of arthritis, it can long whole life. But if there is a large talar tilt, it is difficult to preserve the joint by the supramalleolar osteotomy only. So I combine other procedures like tibialis posterior tendon transfer or subtalar arthrodesis, and it is also subject of another discussion, another topic of presentation. And in regarding the supramalleolar osteotomy only, I recommend to do it only an ankle with a minimal degree of varus talar tilt, which is less than 7.5 degrees in my experience.